Hello, everyone. I welcome you all to the continuing medical education webinar on the topic of prevention and control of typhoid updates and guidelines. My name is Dr. Umair Haider. I am the moderator to today's session. First of all, I'm sorry for last time's technical issues. Now we have switched to a better platform, and we are hopeful that this time it's going to be a user-friendly learning experience for all of you. This webinar is organized under the CME and CD program of the Infection Prevention and Control Foundation. This webinar will be streamed live on Facebook and YouTube channels tomorrow. This CME webinar comes with 2 CME credits, which are issued by the University of Health Sciences. And all of you will receive the CME certificates as well in your emails. I'm joined by Dr. Farooq from Penn State University, who is co-moderating the session with me. He's the Associate Professor of Medicine at Penn State University College of Medicine. Thank you, Dr. Farooq, for joining us. It's very early morning over there. Now I'd like to request Dr. Farooq to briefly highlight the situation of typhoid fever in Pakistan before we go to Dr. Soumya Iqtidar, our first speaker.
Thank you, Dr. Umair Haider, for the kind introduction. Assalamu alaikum, everyone. How is everyone on this wonderful day? So today we plan to talk about typhoid. I recall typhoid to be, some outbreaks when I was practicing in Pakistan, or I was in the med school. So we used to have some weather-related or foodborne illness, some outbreaks. But now typhoid is becoming more like an endemic. It's spreading rapidly, and the scale is quite large. The other problem which we are dealing with is that there is a typhoid, then there is drug-resistant, which is multi-drug resistant, and extensive drug-resistant typhoid. So the bug has become like a super bug and a monster bug. So it's really going out of control. So today, we have in this session, we have 2 very well-renowned speakers. They will talk about how to manage the regular typhoid, the super bug typhoid, and really the mega or the monster bug typhoid. So what are the current guidelines? If you are the physician treating this patient, how would you manage? And then we have Dr. In the second session, we will talk about how to prevent it. So roll of vaccine, how to roll it out. So really treatment focused and prevention focused. So clean water. That is the basic need to avoid all of this. So with that, I think I would like to introduce our first speaker, Dr. Soumya Iqtidar. She does not need a lot of big introduction. She's already very well known in her services in the public health domain, a proud alumni from King Edward Medical University, which is my alma mater as well. So I always proudly present that. She's currently serving in her role as Associate Professor of Medicine at King Edward University, but I see her really role larger than in education as well as in the public health and policy. Anytime the government needs an expert in dengue fever, in COVID, and other public health emergencies, she is the choice. She's the go-to person. So without any further delay, I will request Dr. Soumya Iqtidar to take over and start her session.
Thank you very much, Dr. Umar, for your very kind introduction. Assalamu alaikum, ladies and gentlemen. I'm talking about a disease which is the increasing problem in third world countries, and it has emerged as a menace in countries like Pakistan. And since 2000, it has become the topmost problem related to waterborne diseases in Pakistan. So before I jump on to typhoid, let me remind you that every year a new bug comes and we have to face it. If some of you remember, there was an Ebola outbreak in the African countries a few years ago, and everybody was talking about Ebola. Then came the viruses, and dengue virus became the talk of the town, especially in Punjab and in Pakistan, where a huge epidemic was there in 2011 and 2012, early start of 2012. There are other viruses which always, bug us, and they are becoming increasingly prevalent in our country. And now we are facing with another pandemic, which is once in a century pandemic, which is SARS-CoV-2 virus causing COVID-19 disease. But before all these viruses, there was a woman who was most helpless, yet she was the most dangerous woman in America. And she was named Typhoid Mary. And that's how we remember the typhoid fever, because she was the one who was a cook by profession, and she infected 47 people and 3 people lost their lives. So she changed her employment, but the members of the household always got sick. She was forced into containment, and she was under prison and containment for a very long time. But because she had that passion of cooking and it was her profession, so she could no longer hold herself back, and she assumed a false name and began cooking again, and of course infecting numerous other people. So ladies and gentlemen, you all are familiar with typhoid fever, and I will be sharing some facts and figures about this disease with you today, and we will be looking at global scenario and the Pakistani perspective of this disease, and what are superbugs, what is MDR and XDR. In my talk today, I'm going to introduce you to this bacteria, give you a little history. We will be talking about the clinical course of the disease, how do you diagnose it, what are the right tests to perform and how to interpret them. What do we mean by MDR and XDR typhoid? What are the treatment guidelines which are modified in the light of evidence-based medicine? And what is the vaccination? This will be covered in the second session by a very esteemed speaker, Dr. Rana Jawad Zahid. So talking about typhoid. Typhoid is a life-threatening illness which is caused by a bacteria which is known as Salmonella typhi, and the disease that it causes is called typhoid fever or enteric fever, or sometimes previously it was labeled as bilious fever or yellow jack fever. Typhoid bacterium, the Salmonella typhi, is a gram-negative short bacillus that is motile because it has flagella. And it causes a multi-system illness, and it is transmitted by ingestion of contaminated food or water. So the route of transmission is orophycal. It was named, this bacteria was named after Daniel Elmer Selman, which was an American veterinary pathologist who first time described this as Salmonella enterica. Around 430 to 426 before Christ, it was believed that typhoid fever killed 1/3 of the population in Athens. And this was long disputed, but after a DNA discovery in 2006, it was determined that the bacteria which caused so many casualties was actually this typhoid bacteria. Between 2004 to 2005, an outbreak was also seen in Dominican Republic, and 42,000 cases were reported with 412 deaths. If we talk about number of cases of typhoid worldwide, cases are reported, and we lose about 150,000 precious lives to this multi-system illness. Without treatment, it has a high case fatality rate, and it is about 10 to 30%. But with evolving treatments and newer therapies, we can reduce this mortality to reduce it up to 1 to 4%. If we in Pakistan, around 21 million people contract typhoid annually, and it is most commonly seen in Asian countries among Pakistani nationals. Children are particularly affected by typhoid, and in 2017, we had an alarming outbreak of typhoid in the pediatric population. And 63% of typhoid cases and 70% of the typhoid deaths in our country are among children who are younger than 15 years of age. In 2016, November, there were about 5,274 cases of typhoid reported in the provincial disease surveillance system of Sindh. And that is when it gained attention that this is an alarmingly increasing number in the national scenario, and especially in the province of Sindh. And then the Pakistan government, it prioritized on introducing this vaccine, which is the typhoid conjugate vaccine, which we will be discussing the rollout program in the next lecture. So the typhoid conjugate vaccine was formally introduced in Sindh as part of vaccination program in November 2019. If we talk about Punjab, which is the biggest province of the country, 12% of suspected typhoid cases, they turn out to be positive. And out of them, the alarming situation that 93% of these positive cases are drug-resistant cases. 82.4 are extensive drug resistance and 10.3% are multi-drug resistance. And I will be covering in my next few slides what do I mean by MDR, which is multi-drug resistant, and XDR, which is extensive drug resistance typhoid fever. As I mentioned earlier, the route of transmission is orophycal, and the bacteria enters the bloodstream through contaminated water and food, and then it travels to your small intestine. And the white blood cells, they carry the disease to liver, spleen, and bone marrow, where it starts reproducing and then re-enters the bloodstream. And this bacteria, it also invades our biliary system, our gallbladder, and the lymphatic tissues of the bowel. And this is how the disease disseminates throughout the body. Patients, they present to you with acute illness, and when they are febrile and they're suffering from this disease, then they can excrete this bacteria through their feces, and the feces, if it contaminates the water supply, it becomes infectious as well. So after the acute illness, about 3 to 5% of the people, they become carriers of the disease. And this is also one point which leads to rapid dissemination of the disease in the community. Sometimes even the illness is unnoticed and the patients are not symptomatic, but still they become the long-term carriers, and the bacteria, they continue to multiply in the gallbladder, bile duct, and liver, and then they keep on passing this through the feces and contaminating the surroundings. Clinically, the patients present to you with a febrile illness. They have fever, which lasts from 5 to 21 days. And the majority of the patients, they also exhibit abdominal symptoms like pain, nausea, and vomiting. Patients have coated tongue, they complain of weakness, fatigue, muscle aches, body aches, loss of appetite and weight, sometimes diarrhea or constipation or abdominal distension. There is a characteristic rash that you can come across in these patients, which is a small maculopapular rash visible more on the trunk. In the first week, you have fever, relative bradycardia, malaise, and headache. Your cell count starts decreasing. Usually there is a drop in the white cell counts, along with eosinopenia, and relatively lymphocyte number increases. And this is the time when the cultures are positive for Salmonella typhi. This is the rash that I'm talking about. These are known as rose spots. These are papules about 2 to 3 millimeters in diameter, and it appears usually in the second week of the illness, and it affects the trunks mainly. And this is pathognomic of this disease. If we talk about complications, then serious complications, they occur in about 10% of the cases, and they are more commonly seen in patients who have a prolonged illness, and the disease, if it exceeds the time of 2 weeks, then the complications arise. Usually in the third week, we come across serious complications, which can be in the form of intestinal hemorrhage or perforation, leading to shock or sudden drop in temperature, and dark or fresh blood in the stools. Rarely we have complications by involving other systems of the body, like lungs in the form of pneumonia, like urine in the form of urinary detention, gallbladder leading to cholecystitis, kidneys leading to nephritis, bones leading to osteomyelitis, heart leading to myocarditis, and sometimes have psychotic symptoms. of these patients who recover from their illness, they become the gallbladder carriers and long-term carriers carrying on the disease cycle. If we talk about the investigations and how to diagnose this disease, the standard for diagnosis, or the gold standard, I should say, has long been the culture isolation of the organisms, and cultures are widely considered to be 100% specific for this infection. The other lab findings which can help us in making a diagnosis are your CBC, which shows usually a slight rise in erythrocyte sedimentation rate, anemia, normal blood counts. Occasionally, you have relative leukopenia and thrombocytopenia. Liver function tests, as you all know, in many of the bacterial and viral illnesses are disturbed, and mild transaminases and rise in the bilirubin levels are seen in patients of typhoid commonly. LFTs must be done in all patients whom you are suspecting typhoid and you must also differentiate it from acute viral hepatitis, which can also begin with a non-localizing fever. In the electrolytes, we see mild hyponatremia and hypokalemia sometimes, and all this picture is very common in other viral illnesses or acute febrile illnesses as well. So we must differentiate it from two common other diseases which are present in our country, which are dengue and malaria, and they should be ruled out. As I told you in the beginning, the culture or the isolation of the bacteria remains the gold standard for treatment. And this culture can be done from many body fluids. And it can be taken from blood, from bone marrow, from urine, even from the rose spot biopsy extracts, from the duodenal aspirates or stool. And the other two tests, which are commonly prescribed by many physicians previously, were the serological test, which is very commonly known, Vidal test, everybody talks about it, and typhi.IgM and IgG tests, which are serological tests. They are no longer recommended for diagnosis of enteric fever, and we must not use them for confirmation of dengue for typhoid fever, but the gold standard remains the culture of Salmonella typhi. So blood cultures are positive in 40 to 80% of the cases, usually early in the course of the disease. Bone marrow aspirate or culture of bone marrow is 90% sensitive if it is done at least 5 days after commencement of antibiotics. However, the technique is usually cumbersome, it's extremely painful, so commonly it is not prescribed by the physicians. Cultures from stool are usually not positive in the early disease, so the blood culture remains the gold standard for the diagnosis of typhoid, and these must be sent whenever you are suspecting a patient of typhoid fever, and this should be sent before starting the antibiotic therapy. Once you have sent the blood cultures, you can start with the empirical treatment of typhoid, and blood cultures should always be taken when the patient is febrile, but even when the patient is not febrile, but you are suspecting typhoid because of other symptoms, and if there is history of fever and other features suggestive of typhoid, you should still send the blood cultures. Blood cultures can still be sent even if the patient is already on antibiotics. A blood culture report is usually available in around a week's time after sample submission, in cases where there is no growth of any microorganism. But in case of a positive blood culture, an early report is usually given by most of the labs as early as 3 to 4 days, which report which organism is present on the culture, and you can then confirm the report after 7 days. On a negative culture, you cannot rule out that typhoid is not present. If you have a strong clinical suspicion, you must repeat a blood culture. And if your fever is not responding in 7 to 9 days of commencement of treatment, even then you need to repeat a culture. Now, another important thing that I want to highlight over here is the volume of blood culture, one of the most of this bacteria from the patients. So at least send 20 ml of blood from an adult patient, and this should be inoculated in 2 different bottles, 10 ml each, both for aerobic and anaerobic blood cultures. A preliminary report, as I told you earlier, is usually available in 3 to 4 days, which shows you that this is gram-negative rods, and which is followed by non-lactose fermenters oxidase negative from a blood culture. And the final report, it comes in a week's time. And these are earlier reports are highly suggestive of salmonella and should be treated on the lines of typhoid fever. Serological tests, as I already told you, are not recommended in the diagnosis. Both Widal test and typhoid antibodies, which you do by IgM and IgG, have low sensitivity and specificity, and they do not provide information on the sensitivity of antimicrobial therapy that you need to use to treat these patients. So they are not recommended in the diagnosis of typhoid fever. Coming on to the classification. Is based on the drug resistance status. So there are typhoid fever who are not resistant to drugs and they respond excellently to your first-line antibiotics, but they are very, very rare now. We mostly come across multi-drug resistant typhoid fevers or extensive drug resistance typhoid fever, and this is because of the injudicious use of antibiotics and antimicrobial resistance, which is emerging as a major problem in our country, all over the world, but also in our country. So, non-resistant typhoid fever. A typhoid fever which is caused by Salmonella typhi or paratyphi, A, B, or C strains, which are sensitive to your first-line drugs. And third-generation cephalosporins with or without resistant to second-line drugs are known as non-resistant typhoid fevers. And the first-line drugs that we use are chloramphenicol, ampicillin, trimethoprim, sulfamethoxazole commonly. So if they are sensitive to these drugs, they are known as non-resistant typhoid fever. Then comes the second classification class, which is the multi-drug resistant typhoid fever. And these are those strains of paratyphi or typhoid which are resistant to first-line drugs, sensitive to third-generation cephalosporins with or without resistance to second-line drugs. And the second-line drugs are fluoroquinolones, which were commonly prescribed in previous few years to treat this typhoid fever. And then comes the bug or drug resistant typhoid fever, which has become a major problem to all the physicians and the patients as well, because the typhoid bacteria has become so resistant that no matter which antibiotic you give, they do not respond. So these are the strains which are resistant to all the recommended antibiotics for typhoid fever, which are first-line drugs, including chloramphenicol, ampicillin, trimethoprim, sulfamethoxazole, second-line drugs, which are fluoroquinolines, and third-generation cephalosporins. And third-generation cephalosporins include both oral and injectable in the form of cefixime or ceftriaxone. So how will you treat them? So this is the next golden question. So the treatment for any disease is, you all know, in the form of a supportive treatment and a definitive treatment. And because we are bound to have cultures for diagnosis of this disease, so we start with an empirical treatment in typhoid fever. In the supportive treatment, you need to bring the fever down by giving antipyretics. You advise adequate rest to the patient, hydrate the patient well, and correct the electrolytes and fluid imbalances if there are any. You tell the patient, because if they are experiencing abdominal symptoms, then they should have a soft diet, and patients, they tolerate the soft diet better than the routine diet. If the patient is severely ill, then you need to monitor all the parameters like blood pressure, blood sugar, CBC, platelet, liver function, electrolytes, and hospitalize these patients. Coming on to the antibiotic therapy. Empirically, we start the treatment in these patients, and they should be started as soon as possible to prevent the complications, relapse, and the development of chronic carriers. So it is usually treated with a single agent antibiotic, and antimicrobial susceptibilities can be determined to guide treatment by sending a culture. But start the empirical treatment with, usually we start with cephalosporins. Like oral, we can give cefixime, which is usually given in a dose of 400 milligram 12 hourly, or in the injectable ceftriaxone, which is 1 gram 12 hourly, or 2 grams once a day, you can also prescribe. If the initial therapy with oral cefixime patient is not improving after 5 days, or if there are any signs of complications they appear, then you should switch to the injectable therapy in the form of IV ceftriaxone. Once the results of the cultures are available, then you change your antibiotic regime according to the sensitivity report that you get of the culture. You should avoid prescribing azithromycin as an empirical choice of treatment. We've been very commonly prescribing azithromycin. You know, it has been prescribed very rampantly in the COVID-19 as well. But you should avoid this as an empirical choice of treatment, and it should be reserved for extensively drug-resistant typhoid only, and guided by the culture and sensitivity report. The definitive treatment, that is the susceptible typhoid or a non-resistant typhoid, this should include the first-line drugs, which include ampicillin, I told you, chloramphenicol or fluoroquinolines, and you need to complete a 14 days of treatment. For MDR typhoid that are resistant to first-line drugs, but these strains are usually sensitive to third-generation cephalosporins. You start with the third-generation cephalosporins, which can be oral or injectable, and you continue them for a period of 2 weeks, because the shorter courses, they may lead to relapse of the disease. In the XDR typhoid, which is the real problem these days, because we are seeing extensively drug-resistant typhoid in most of the patients that we come across. And these are the patients who are resistant to all recommended antibiotics of typhoid fever, but they are sensitive to 2 groups, either azithromycin or carbapenems. So if the patient is clinically stable and you have extensive drug-resistant typhoid fever, you stop the cephalosporins that you were initially giving as an empirical therapy, and you start with the azithromycin, and the dose is according to the body weight. If your weight is less than 60 kg, you give 1 gram loading dose orally, followed by 500 milligram once a day for 7 to 10 days. If your weight is more than 60 kg, you give 1 gram for 7 to 10 days. And this is the recommended treatment. If the patient is unable to take orally, is hemodynamically stable and deteriorating rapidly, or he has developed any complications, then you need to admit these patients to a tertiary care hospital where specialist care is provided. And the choice of antibiotics in this situation would be carbapenems, as I told you, which can be given in the form of imipenem, meropenem, or ertapenem. And we prescribe commonly meropenem in the dose of 1 gram 8 hourly. And again, the duration of the illness should not be less than 14 days. Then come those set of people who develop any complications. So the complications or complicated typhoid is labeled when you have a suspected or a culture proven enteric fever with any of the following features like jaundice, drowsiness, severe abdominal pain. You have bleeding episode in the form of intestinal hemorrhage, or patient goes into sepsis or septic shock. And these patients, which are labeled as complicated enteric fever patients, should always be managed in a tertiary care center in a hospital setting. Then, as we all say, prevention is always better than cure. And this is the era of preventive medicine. And we are very fortunate to have lots of advancements in many diseases in the form of vaccines. So previously, there were 2 vaccines against typhoid available in Pakistan. One of them was a single-dose injectable polysaccharide vaccine, which was given to children above 2 years of age, and the revaccination was needed every 3 years for continued protection. But Now we have launched another new vaccine which is available. 2019 we launched it in Sindh, and in 2021 February a campaign was started in the Punjab province as well, in which a single dose typhoid conjugate vaccine is approved for use in children more than 6 months of age, and it offers protection for at least 3 years to adults and children and infants over 6 months of age. But the revaccination schedule is under study at the moment. At the moment, we are only giving single dose vaccine, and we assume that it is going to give protection for more than 5 years. But we all should know that neither vaccine is 100% effective, and we always require repeat immunizations because the effectiveness of the vaccine programs, they diminish over time. So vaccination should not only be limited to children. It is started as a campaign in pediatric population because this was the most affected population, which should all, there are high risk groups who should also be vaccinated, which include your healthcare workers, especially your food handlers, and people who are household members of a confirmed case. So other than the vaccine, the other methods of prevention are very simple, and we advocate them as good health practices all the time. And I want to re-emphasize today that there is a major role of prevention of typhoid fever by taking very, very simple measures like washing your hands, especially after using toilet and before eating, drinking boiled water, taking clean, fresh and vegetables which are peeled, and eat food that have been thoroughly cooked, and avoid flavored ice and juices because they may not have been made with the boiled water and it may be contaminated, and spread this message to the entire community to adopt good health practices to avoid this disease. As I told you earlier, the typhoid conjugate vaccine campaign is continued. It is being carried out in Islamabad, Punjab, and Sindh. And in special campaign, in first phase, all children between 9 months to 15 years of age are being vaccinated. So, coming on to the conclusion of today's talk, we always say that prevention is better than cure, and if Typhoid Mary had cleaned her hands and not spread this disease, we would have not been suffering from this deadly disease. So clean water, sanitation, and hygienic handling of foodstuffs are the key to prevention and control of the disease. Blood culture remains the standard diagnostic tool. Avoid the misuse of antibiotics to decrease the drug resistance, and encourage your people around you to participate in this vaccination campaign which is going on in the country. Thank you very much.
Wonderful talk. What I enjoyed, this was simple presentation in terms of easy to understand, and I have not managed any patient with typhoid recently, and I think this was a good update for me as well. I hope everybody liked it. So really, the when it comes to the significance, it's pretty bad, right? Mortality is high, and the complications, once you go into in the complication phase, we are actually backpedaling against so many different things. So all those typhoid testing, I think you highlighted in diagnosis that all those, the antibody testing, so they are not valid anymore, right? So maybe if you want to highlight more. So the only gold standard test is blood culture, right?
Yes, that's true.
Okay, so I think there are good questions. One question was about, what about the multi-drug resistant variant despite vaccination?
See, as I told you in the beginning, none of the vaccines are 100% guarantee you that you are not going to get the disease. So even after vaccination, you can get the disease. So you need to continue to have good health practices by washing your hands often and boiling your water and cooking your food well. So they need to be in place. Same, I would say that is we are going with the pandemic of COVID-19, and now we have the COVID-19 vaccine. But COVID-19 vaccine is not going to be 100% make you safe from not contracting the disease. But you need to adopt the practices like social distancing and hand hygiene and use of face masks. So same is the true for all infectious diseases. None of the vaccines is 100% safe, and you may still can acquire the disease. So you should continue with following all the good practices.
No, thank you. I fully agree. I think the vaccination is great, but we still continue to do the good citizenship. And I think this applies to COVID as well. The other, I think, very good question was that in the relationship to COVID, drug resistance and vaccine, that now the azithromycin is being widely used.
Yes.
So what are your comments about the impact of wide use of azithromycin in the midst of COVID upon the future of the drug-resistant typhoid?
Thank you very much. I think it's
this drug too.
Yeah, thank you very much. I think it's a very pertinent question because we all know that whenever even we suspect of a COVID disease and we start taking azithromycin. Believe me, I do not prescribe any antibiotic to COVID-19 patients unless and until they have an element of sepsis or I have an evidence that there is superadded bacterial infection. We all know that antibiotics are used to treat bacteria and not viruses, and COVID-19 is caused by SARS-CoV-2. There had been initial studies which showed the antiviral properties of this antibiotic, and they came to these recommendations of using these antibiotics. But recently, there has been a meta-analysis which is published which showed no efficacy of azithromycin in treating COVID-19 patients. So if you do not have any superadded bacterial infection, there is no need to give antibiotics, and we should spare this antibiotic, especially in our part of the country, which is suffering from, which has a large number of extensive drug-resistant cases. So you should not prescribe it. If you have to prescribe it, then please make sure that you complete the dose and duration of the treatment to avoid the antimicrobial resistance.
Thank you. Thank you for the wonderful answer. I think there is another question which is related to the vaccination. Maybe I can take your comment and then we will ask our second speaker to comment, is that once somebody is vaccinated, how do you measure or check the efficacy of the vaccine? Is there a test, like an antibody testing, available to check that or not for this condition?
Some of the labs are providing antibodies against the spike protein which the vaccine acts on, and the levels of the antibodies can be determined by ELISA. But again, we do not know for how long these antibodies remain stable in your blood and what is the threshold level, which is protective for you. So once you are vaccinated, and another thing I wanted to add over here, because this just rose as an issue a few days back and it was highlighted in the media, that after first dose of vaccination, you are not immune to the disease. You need to complete both doses, and even after that, you are not 100% sure that you will not be able to get this disease any further. So 2 doses, and after 2 weeks of the second dose, we assume that the antibody titer is enough to protect you from the disease. But even then, there can be occasional cases, but the severity of the illness will be not that much. So continue to take care of yourself by following all the standard operating procedures of COVID-19. And vaccination, after vaccination, I don't think that you need to check your antibodies levels again and again, because they are not going to help you and not give you much information.
No, I appreciate. I think thank you for the question in context of COVID. I think that there was a question in context of typhoid. Is there any way to detect the immunity for typhoid patient? I'm not aware if
no,
if
it's not available at the moment in Pakistan.
Okay, it's not available. And you're right. I think the COVID vaccine. I think the facts you just mentioned, that the antibody, the vaccine really prevents the disease, severe disease, and I think the recent data from Johnson & Johnson, you just saw that there is 100% protection from coming to hospital and dying from the disease. So I think that's that's very strong data. And the good thing is that the real life data, so the two mega studies for the COVID vaccine published in JAMA as well as New England Journal for the real life use. So like really 20 million actual doses and 600,000 doses. The safety data was similar to original trials. So I think we can use this webinar to get the message to public out that if you qualify for the vaccine, go get the vaccine and help others to get vaccine as well. Dr. Umair, back to you. Any more questions which we missed?
There was a question related to the intestinal perforation percentage of the cases that present with typhoid, and the question was that we have seen a rising percentage of intestinal perforation. So how can patients and primary care physicians ensure that typhoid cases are diagnosed earlier and we avoid the cases of intestinal perforation?
Okay, I think it is very important from the primary care physician's point of view that we diagnose the cases earlier. As I told you in the beginning, there is a typical clinical picture of typhoid which shows a fever, which is a step ladder pattern usually, along with abdominal symptoms, a mild rise in your liver function test. So if you have this classical triad, you must keep typhoid fever on top of your differential diagnosis, especially in younger people like less than 15 years of age, because this is one of the most common diagnoses that you come across. If you have a classical picture, like you have thrombocytopenia with mild leukocytosis or even leukopenia along with rose spots, this further enhances your clinical skill to diagnose a typhoid. You empirically start with the treatment of typhoid fever and you send the blood cultures. So initially this what you can do. But if the disease is not responding, the fever is not settling and patient is becoming hemodynamically unstable, or any of the complications arise, like patient is becoming jaundiced or he's drowsy, and the fever is not settling, and there are worsening of the abdominal symptoms like abdominal pain, severe nausea, vomiting, and ileus-like condition, always admit these patients. Because if the disease goes beyond second weeks, there are 5 to 10% chances that the patients will go into a serious complication like intestinal perforation and hemorrhage.
Question, and I think that's the last question we have, was that do we need to check for the resistance pattern in all cases that present, or do you start the treatment on the clinical suspicion, and then if the patient is responding, you don't need to send culture?
As I shared the data with you all earlier, that 83% of the cases, they turned out to be extensive drug resistance. So the percentage is too high. We hardly see any patient who is a non-resistant typhoid. They are all either multi-drug resistant or extensive drug resistance typhoid. So as I mentioned in the presentation as well, you start with the empirical treatment, but before that you need to send a blood culture. And a blood culture tells you the sensitivity pattern of the antibiotics, which gives you a very fair idea in which category the patient falls. The antibiotic resistance report tells you to which antibiotics patient is going to respond, and if he's not responding or not sensitive to all the first line and the third generation cephalosporins, he's multi-drug resistant, and if he's not responding to the second line drugs like fluoroquinolines, then he's extensive drug resistance, and then you need to put these patients on azithromycin or carbapenems.
The first lecture, we have few queries regarding the lecture notes, and lecture notes will be available at the end of both sessions in this platform, and it will also send everybody an email as well, the lecture notes. So don't worry about that. Dr. Soumya, thank you so much again.
Thank you very much for inviting me. It's always a pleasure to join this forum because they disseminate knowledge to not only general public but physicians, and it's always good to see alumni of King Edward Medical University, Dr. Omar.
Thank you.
Thank you so much. I think we should now take Dr. Jawad in. So before I introduce the second lecture and the second speaker, I'd like to highlight the vaccination campaigns that the province of Sindh and Punjab have undertaken, because it was reported that Pakistan is probably the country in the region with reported cases of XDR typhoid, and after that, World Health Organization recommended that mass campaigns be held all over Pakistan. That's where the province of Sindh took the first step, and now the province of Punjab is following. That's why the vaccination for typhoid now has become a really important, effective preventive tool as far as the Pakistan is concerned. And that's what our second topic, typhoid conjugate vaccine rollout in Pakistan, efficacy, safety, coverage, schedule. And to present that lecture, we have Dr. Rana Jawad Asghar with us. He is the alumni of the University of Washington. He is the visiting faculty member of the University of Nebraska, and is also the resident advisor for CDC office in Pakistan. He has his own public health organization as well. Dr. Rana Jawad Asghar, over to you, sir.
Thank you. No, I'm not.
Umar, can I say something as well?
Yes, please.
Yeah. So, and this is what I would like to tell the audience is, like, it's my privilege to be with Dr. Asghar again in this webinar format. The last time, I think, when we did the session about HIV/AIDS, what I learned is that Dr. Asghar has two very prominent qualities. One, he's very authentic. He knows the real life problem and he offers real life solution. So वो किताबी बातें तो सब करते हैं, मैं भी करता हूँ, I'm sure, लेकिन डॉक्टर असगर जो है वो बड़ी ग्राउंड रियलिटी के साथ बात करते हैं. The second thing is, जब भी बोलते हैं दिल से बात करते हैं. So I think that's what we learned from the last webinar. So without further delay, I would like to invite, please आप शुरू करें, and always it's pleasure that जब आप हमें real life situation के से आगाह करते हैं.
Thank you very much, बहुत शुक्रिया. And my privilege and honor आपके इतने अच्छे अल्फाज. But I'm not now CDC resident advisor. I left that position back in December 2018. But I have worked for US CDC for more than 14 years in total. So let's focus on today's talk, which is about typhoid conjugate vaccine rollout in Pakistan. And I have took a liberty add on to the story that, next slide please, that why there is a need now. For me, this is not a matter of pride that Pakistan is the first country which needed this, a vaccine for a disease which is totally preventable by just few basic public health steps. As a public health professional, I feel ashamed that when someone in international meetings tells that Pakistan is the first country to report XDR, Pakistan is the first country to report another deadly fungus disease, which is Candida auris. And we are one of the 2 countries left who are still sometimes export poliomyelitis cases. So, that makes me not happy. And that's why in my presentation, I have tried to look into those issues and maybe share my stories with you. Fortunately or unfortunately, both in XDR typhoid outbreak, which started from Hyderabad and then spread to Karachi and then to the remaining part of Pakistan, and also the Candida auris, which is again a deadly disease, which appeared simultaneously in 4 or 5 different countries in different continents of the world, and Pakistan was one of the first few 5, 6 countries which reported this. So fortunately or unfortunately, both of these outbreak investigations I was supervising as a CDC resident advisor. So I was able to, number one, investigate and to try, and with my team, I tried to understand what were the reasons. So I'm going to give you a little flavor of that today, that why there is a need, and then we will talk about certainly about vaccine efficacy, safety, coverage, and schedule. Next, please. So I will not repeat those things. The figures have been given to by Dr. Soumya Iqtidar, the global problem, and then antibody resistance, and then XDR, which is a totally new problem. Next, please. She has covered it very well, but I want you to pay attention to number 2nd bullet, which is that normally 2 to 4 years children have a pretty high incidence of typhoid, and the children who are less than 2 years old have even higher incidence of this disease. So it is more common as you are younger, become less common as you grow older. And we all know that this is associated with low socioeconomic status. Next, please. Next slide. So she talked about the one step back. Okay. So multi-drug resistance, she has covered a lot, and this is chlorophenicol, resistant to ampicillin, and cotrimoxazole. When I was doing my master's at University of Washington, and this is in 90s, no one wants to study infectious diseases at that time. At least when you are in the United States. Nearly all my class fellows were, studying different, or doing their thesis on different types of cancers, because Seattle has one of the best cancer center in the country. Infectious diseases were there, but only in the shape of HIV. And I didn't want to do both of these because everyone else was doing this. And before going to US, I was a family physician. And in my practice, I had seen this issue of assumed multi-drug drug resistance to typhoid patients, and then physicians trying to give all the different drugs without even knowing and going for culture sensitivity. At that time, for a family physician, it was very difficult to order any culture sensitivity, because the whole concept was not there that if you go to a family physician, you expect a treatment right there. And even with, if you go to a consultant, lab diagnosis or culture sensitivity was never or very rarely done, I should say that. So from that mind frame, when I went to US, I wanted to know what is the actual problem of MDR typhoid. Because I was thinking at that time in Pakistan that maybe we are just, because there is no data available, so physicians are just trying their hunch and going from one medicine to another. So it will be better if we know what is the ground situation, so we can appropriately prescribe medicines, different medicine, which may not be very expensive to the patient and still effective. And then that whole study became my master's level thesis, and I actually did. I looked into the Vidal test effectiveness in identifying cases. So, but that's the story for some other time. But that's how my interest in typhoid started many years back. In 1970, H58 was a strain, and which is MDR, and which is now dominant pretty much globally. It started from Asia, Sub-Saharan Africa, Latin America, but now it's a dominant strain. Next, please. So XDR, as you have already now know, that is resistant to pretty much every drug in our arsenal: chlorphenicol, ampicillin, cotrimoxazole, streptomycin, fluoroquinolones, and third-generation cephalosporin. It emerged from Pakistan, as I was telling you, in 2016, and we talk about this azithromycin is effective, but resistance is already being reported. Next, please. So, give you just a timeline of typhoid fever, Salmonella typhi, and how different resistance, came into the picture. Next, please. So, basically, in January 2017, Awahan informed Sindh Disease Surveillance Response Units, which were fielded by Pakistan Field Epidemiology and Laboratory Training Program, which is US CDC program, and I was acting as its resident advisor. They have identified 14 cases of Salmonella typhi, which are resistant to previous known, most of the drugs. And then our team started investigation, and Pakistan's first typhoid surveillance system was set up first in Hyderabad and then into Karachi also. And if you look at data now, and I'm talking about just 3-4 years, there are 14,000 confirmed cases in Karachi alone. Next, please. So complication arises 10 to 15% of untreated patients. This is just regular Salmonella typhi, and she has already mentioned intestinal perforation, hemorrhage, and septic shock. And the highest incidence is in Southeast Asia and Indian subcontinent. And basically, again, matter of shame for us that Pakistan, India, and Bangladesh is 85% of the world cases. Next, please. So this is just the place where it all started in Hyderabad. Some members of my outbreak investigation team, and the story was published by Take on Typhoid later. Next, please. So look at the map of Hyderabad city. And remember this, all outbreaks are like stories. You want to know how it started, from where it started, who was the first case or the index case. Many of us now are well versed in epidemiology or outbreak investigation after COVID-19. But it's always a story you need to identify. It's like a crime scene, you need to find what happened, where happened, how it happened. And that's the best way then to control the disease if you understand the reasons why it started. So it started in an area, if you look at this map, on the left side you can see the river of Sindh and the city which is on the banks of the river of Sindh. First cases started in an area which was next to the river Sindh, and it had waste disposal unit, huge, one of the kind I have seen. But unfortunately, they were all non-functional. Huge setups, but they were non-functional, and pretty much throwing raw sewer to the water lines, to the Sindh, river of Sindh. The next cases we beginning to find, and remember we started with only 14 cases, 14 cases in a city, and then our team who were working in Sindh and Hyderabad, some of them may already have joined in today's session, they started to find more cases in the downstream area of that of the first geographic area. And when we went there, we saw that the whole water supply lines, which were actually illegal, but were going through again sewerage line, because if they put those new lines on the road, they will be easily broken by the traffic. So what they did was that they put them in the small sewerage lines just to protect those water lines, but not thinking that once they start pumping water, they will be actually not only pumping the water from the from the banks, the shallow water from the banks of River Sindh, but also it will come through all the sewage lines to their home. I saw there, and I actually, two guys were making big day. They were cooking big days, and I asked them to show the water which they are using in cooking that. And believe me, it was pure sewage water, brown in color, but that's how the life there was. So that's how it's from a small area in Hyderabad with 14 cases, it started, and slowly other areas started to become infected with a mutant of a disease for which we have only 1 or 2 medicines left. Next, please. Just to show you the picture of, and if you look on the left side, the blue colors cases are, let's say, non-resistant typhoid fever, and the red are the XDR. And if you look at it, that slowly, in the beginning it was all blue, but slowly predominant strain, and Dr. Somia has given you the exact numbers, basically replaced the original XDR into the XDR version. And we have seen this happening right in front of our eyes in the COVID-19 pandemic also. The strain from the UK strain is pretty much started from the eastern side of London, but pretty much within weeks have replaced the previous strain up to 95% in some areas. Because when the mutation happens, and if it is helpful for the virus or the bacteria to survive, simple is that it will predominate and replace the original strains. Next, please. And this is like 3 years, actually pretty much 4-year data on this slide. And again, thanks to Pakistan Field Epidemiology and Laboratory Training Program and the fellows who are working on this, this kind of disease data is very rare in Pakistan. And before COVID-19, there was absolutely no place where you could find that type of data of fairy disease. But again, many of them are joining today's web session. So thanks to them that we were able to see how the virus is moving, Salmonella typhi is moving up, XDR, this is all XDR. And then after the vaccination started in the later part, it beginning to go down in those areas. But again, there are many caveats on the last year data, which is 2020. Because of the pandemic, most of the surveillance systems in the country were not functioning on the full capacity. So we are not sure that these decrease in the cases, reported cases, are actually decreased in actual numbers, or is just the reporting issue because of a pandemic. I think this year, this situation will become more clear. Next, please. So back in 2018, I think November or December, I did this a simple math for the government of Sindh. At that time, Sindh had around 4,000 cases, and just looking at the how we see on the how we see that fraction of cases which are reported as compared to the actual cases in the community could be. We estimated burden of disease of at that time, that is December 18 or November 18, around 40,000 cases approximately. And we calculated that the Sindh government has already paid 2.4 to 4 billion rupees already. They have spent from their exchequer, or the people of Sindh has paid, and these are just direct costs. If you calculate indirect costs, that that could go many billions of rupees more. The point I made this slide was to show the government of Sindh that investing in clean water in those areas could have saved you billions of rupees. And the disease, we are not just talking about disease or mortality, but just think about how much saving you could have done by investing on a good quality water supply or sanitation line. And I plead them that I'm not saying that you do it for the whole of Karachi or the whole of Hyderabad. Just focus on those areas where we have bigger problem, because once the source will go down, then slowly things will get better. Next, please. So again, this data, thanks to one of my students, Munazza, this data has not been there, and I think it's still very unique. She presented this work in US CDC's annual conference of Epidemic Intelligence Service, which is one of the most prestigious and hard to get, accepted conferences. The acceptance rate in that conference is less than 3% sometimes, and sometimes 5%. That means 95% submissions are rejected. In that conference, not only she presented that unique data, but also got the global first prize on her presentation. And what we looked at it, when XDR was starting, again, we didn't have data, and I was in Hyderabad, and we discussed that how could we get some information that XDR is actually dangerous or not dangerous. And so she based her study in 4 tertiary care hospitals in Hyderabad and came up with significant difference in both morbidity and mortality. And these are the differences are, as an epidemiologist, we say, statistically significant. That means these differences are not by chance. These are real-time differences that complications increased from 18 to 38%, ileal perforations from 14% to 23%, and mortality 0.6% to 1.8% XDR. And there is one important caveat here again. This is not about someone having XDR in a far-flung area and not getting treatment, because then your mortality and morbidity or even ileal perforation goes up. This data is from those hospitals where all tertiary care facilities were there. So the patients have better chance of survival or avoiding, the complications. So, and if those things were not there, these complications and mortality rates may have gone many times higher. Next, please. So, how to prevent? And you are thinking I'm just going to talk about vaccines. Vaccines are important, and I just got a week ago got my COVID-19 vaccine, and I'm looking forward to second dose of it. All children need to go and get vaccines for our primary, the necessary or essential vaccines all of our kids take. But then we need to take a pause and think about how many vaccines we will need if we do not correct our basic problems. Next, please. So basically, if you had a clean water and sanitation, you didn't have this problem. Kids in USA don't require typhoid vaccine. They do not require even hepatitis vaccine unless they are coming here. Even polio, I was 20 years ago, I was in England, and there they had stopped even BCG vaccine because they controlled the situation of tuberculosis in their country, and in fact they don't need that vaccine. So what is important? So if we have clean water, if we were properly disposing of our waste material, not only our kids can be saved from typhoid, XDR typhoid, polio, hepatitis A, so many other diseases. So why we are not working on this? But the vaccine of any of these infectious diseases is important and should be given, especially the most vulnerable population. For example, if there is an outbreak, you should give them. If an area you cannot provide clean water or sanitation, and you are worried about this outbreak situation, go ahead. But think about long term also. Next, please. So in this global world, nearly 2 billion people do, the water they drink is contaminated with feces. And I just mentioned that, it's so many diseases which only a dirty water can give you. Diarrhea, cholera, dysentery, typhoid, polio, just to name a few. And contaminated drinking water is estimated to cause 5 lakh diarrheal deaths each year. 5 lakh every year. And if you look at those numbers, majority of them will be our part of the world. By 2025, half of the world's population will be living in water-stressed area. In least developed countries, 22% of healthcare facilities have no water service, 21% no sanitation service, and 22% no waste management service. If that's the situation of our healthcare facilities, and I am telling you that even in Pakistan situation is, pretty much the same. Just go to any restroom in any even any public restroom, bathroom in any big hospital in big city, or go to similar situation in smaller cities, and you will know what is our problem, what are our health problems, and no matter how many vaccines we bring in, we are going to face different challenges. Next, please. I show this graph to I used to show this graph to all my incoming class of doctors who used to come for a 2-year program. And I will remove all those, what's written on those arrows and ask them, just look at this graph and tell me, and this is, US data, the true death rate because of infectious diseases in US, and what were the reasons that why we start seeing drop in deaths, infectious diseases deaths. And many students, nearly all, basically give this credit to antibiotics, vaccines. But if you look at it, that before the first use of penicillin, which is after 1940, the decline was like 80% already. So what happened in the early phase was actually in US, the clean water or chlorination of water laws were passed and population started to get clean water. Penicillin's antibody came much later. Actually, vaccines in real term came much later. Infectious diseases were already on the defeat. So the reason I show this slide, that as a clinician myself, and I worked as a clinician for many years, we just want to have a pill or a vaccine to manage our problems. We don't think about simple measures which we can take and not only avoid one disease, but multiple diseases. Next, please. Next. So now, because I'm supposed to talk about vaccines also, and especially typhoid vaccine, and Dr. Sonia has mentioned those that we used to have oral and injectable, which was unconjugated vaccine. And both of this issue was that oral was you need to give those who are above 6 years of age, and injectable unconjugated one you can only give to 2 years and above. And the data I have shown you earlier, the most cases or the highest risk group is the age group of 2 years and under. So was a need of a new vaccine, and that's injectable, basically conjugated vaccine, which is actually attached, making the previous vaccine more complex, and this is you can give this vaccine to anyone from 6 months of age to 45 years of age, and the 6 month of age is important is also that before 6 months, baby should not be it should be exclusively breastfed. And if a baby is exclusively breastfed, his or her risk of getting typhoid is pretty much none. Next. So the previous two vaccines have efficacy of between 55% to 72, 78%. Next, please. And just to give you a comparison of, because someone asked the question of immunity, in this also. So the conjugated one actually, it stimulates B and T cell both instead of just having B cell. And antibody titers, it has the unconjugated had IgM. Instead, it has high IgG. It has high antibody. So, I'm not aware of again that is there a antibody test available for typhoid vaccine. I'm sure if it's not there, it will come soon. But I don't think there is a need to see if you have that titer in you or not. Next, please. So that's why the new vaccine is conjugated vaccine is preferred because it's a single dose after 1 year, and it is around more than 80% effective, and no major side effect has been reported. But again, Pakistan is the first major country in which this is being deployed. Next, please. So I'm not a microbiologist or vaccinologist, so this is gibberish to me also. But basically what it does is conjugate what I feel is polysaccharide with typhoid bacteria to make it a more complex protein, and it has long-lasting protection, require fewer doses, and suitable for 6 months of age and older, and that's why it is being used in routine immunization in Pakistan and probably will be used in other countries also, especially in those areas where we have XDR typhoid strains. Next, please. So, November 2019, Pakistan became the first country to introduce TCV into the routine immunization system. 10 million children were vaccinated in the early phase, and then the pandemic started. And now, after basically lull of 1 year, in February 2021, Islamabad and 12 districts of Punjab province to vaccinate nearly 13 million children between the ages of 9 months to 15 years. Next, please. So why it is, I think we have discussed this, that because previous vaccines were not recommended for children less than 2 years old, and biggest susceptible group is children under 2, and so this focuses or addresses that issue, and it has stronger immune response, and hopefully it will have a longer term protection and can be effective in children eventually as young as 6 months. Next, please. So this is the new vaccine. This is one dose vaccine. 0.0 ml dose is injected intramuscularly. Right now, the recommendation is that 3 years for adults, children and infants over 6 months of age. But we still waiting for studies to give us more clarity on the protection it provides after the dose. Next, please. So indications. So prevention of typhoid fever, and in mass immunization campaign in the event of an outbreak or humanitarian and emergency context based on research assessment. So it is not, this has not been recommended, at least my information is, for mass immunization campaigns around the globe. And I was part of a WHO forum, which is SAGE. I was part of the technical team where we looked at hepatitis E vaccine, which is available, which was effective. And actually, our recommendation was that it should be used where there is a problem, where there is an outbreak, where there is a humanitarian emergency context, where you can't deal with or provide the clean water or sanitation, then sure, give it to those population, but not to everybody, because if you are taking care of your water and sanitation, you may not need that. So it is injected in anterolateral part of the thigh in children, and if the kids are less than 2 years, and deltoid muscle in children above 2 years. Just like any vaccine, do not administer into gluteal muscle. Next, please. So dosage, child and adult, 0.5 ml single dose, and next, please. So contraindications. adverse effects, precautions, just like COVID-19. If you have a history of allergic reactions to drugs or vaccines, talk with your doctor or whoever, and try to learn more about it before you get any vaccine or medicine. If you have severe acute febrile illness, then you should postpone. But minor infection does not matter. May cause mild injections at injection site, fever, headache. Again, the common complaints of any vaccination, just like COVID-19. In pregnancy, no contraindication. Breastfeeding, no contraindication. Next, please. And remember, typhoid conjugate, and that's my point is, typhoid conjugate vaccine does not protect against Salmonella, paratyphi, and other types of non-typhoid Salmonella. And again, check before use, and storage is 2 to 8 degrees Celsius, do not freeze. Once opened, store while between 2 degrees centigrade and 8 degrees centigrade for 6 hours maximum. And I know this part is challenging, because if someone is vaccinating kids in their private practices, because unless you have those many kids, you made an appointment for that vial, otherwise you should throw away that vial if you do after 6 hours. Next, please. So the question of revaccination, when will we be needing second dose? At this time, again, just like COVID-19, we have to wait and see by studying as just think about the vaccination started in 19, everything stopped, in 21 it started. So it will take time to complete those studies, which will see that once you have vaccinated, how long that protection will last. So it's not that something bad about any vaccine, but just like if it's a new disease, new vaccine, you need to spend time. Only then you can tell that this is good for 1 year, 2 years, 3 years. So 3 years have to be passed, and you need to get that data before you can declare that it's good for 3 years. Next, please. And I want to acknowledge Dr. Asif, Dr. Naveed, who are our provincial faculty, one at Hyderabad and one at Karachi DSIU, and the fellows of Pakistan FIIT Sindh, who have done extraordinary work and actually has won multiple global prizes from very prestigious conferences, which are tough to get into it. I also want to thank Take Out Typhoid, Gavi, WHO, and Medicine Sans Frontiers, whose slides I have used. And I think that was the last slide of the presentation. Thank you.
Thank you, Dr. Asghar, for a wonderful talk. As always, there are the facts. These are the facts, some of which I'm sure myself and audience were completely unaware of, especially the real life examples and real life data. I think we have very good questions regarding the risk of getting typhoid from the vaccine. Or is there any risk? And it all depends, I think, what kind of vaccine it is, and then, So what are your thoughts on that?
So what is the question? What is the risk of?
So the question is that, can you get the disease, the typhoid, from the vaccine?
Okay. This question comes many times, especially in the COVID-19 vaccine also, because now everyone wants to discuss different vaccines and how they work. Each vaccine is different. Like in polio, we have attenuated virus, and once in 10 million times, it will get activated. And that's why there is very small risk of getting disease from the vaccine. But again, I'm making a point that in 10 million, you get like one chance. And this is like becoming a millionaire or billionaire by just doing nothing. If you look at statistically, that's so small. So it depends on, but most of the vaccines which they, come to the market after those studies have absolutely, I would say, no chance, are close to zero chance. This is never say never or never say no. Close to zero chance or probability to cause the disease. And now this one, typhoid vaccines, conjugated or unconjugated, in their history of, I don't know, 30 years, 40 years, basically these are a little bit of different techniques, but vaccines are the same way they are making it. I have not even read one single incident where any person has got disease by having the typhoid vaccine. Again, back in England, this was a requirement for me when I was coming to Africa to work, that I had to get vaccine, and so I got the old vaccine injected to me. So I think that they are as safe as you drive outside, take your car. I have never heard anything serious about those vaccines.
Thank you, Dr. Asghar. Dr. Omer, do we have any more questions? I think there was a good comment about from a colleague from Singapore about I think her experience of a case in the country and association of travel of that patient related, travel to Pakistan. So I think the message is that all of us have to do our job to get the message through to primary care providers, the folks at the front lines, to identify these conditions and treat properly, and also participate in the vaccination campaigns. I think your campaigns are very targeted, and I hope that these lead to great outcomes. But I think these kind of comments, when they keep rising about Pakistan, I think it's an alarming and kind of heartbreaking situation too. And that's the purpose of all this activity. So we raise the awareness and we engage everybody to participate in those campaigns. Any other questions which Dr. Omer, you want to take over?
Yeah, so the question from Singapore was really about the disease surveillance and the need of the surveillance-resistant patterns. So I'd like Dr. Asghar to comment on that as well in regard to typhoid surveillance and resistance pattern surveillance.
So when this outbreak started of XDR, the Pakistan Field Epidemiology and Lab Training Program, actually, as I mentioned, set up the very first surveillance of its kind, which actually, by looking at data, you could say it's doing very good work for the last 4 years, making sure, at least in the SIN, that they know what's happening and how it is happening. Just looking at how it is, how the original strain has been replaced, are being replaced by XDR. So that's the only surveillance system which is working on salmonella typhi in the whole of country. Even though I was the CDC resident advisor of the whole of Pakistan, but that work was extraordinarily was done because the government of Sindh actually facilitated and allowed their staff to collect this information. Setting up a surveillance system in our part of the world raises many eyebrows, and the governments are not always open to sharing this information that that they have so much of any disease. So even though in other countries reporting of disease is a common phenomenon, you have to work here with very strong nerves and a lot of patience to get that information and bring them on the table.
I have one last question for you. So WHO recommended that population, I'm not sure about the category of the population, that certain population should be mass vaccinated in Pakistan if typhoid is concerned. And then government of Sindh started it, and then government of Punjab is now following it. It's a massive effort that is undergoing right now. How do you comment on that? How much role it will play in the prevention of different cases in Pakistan?
So here is the point. If we could have fixed our water problem in that small part of Hyderabad and sanitation, we didn't need it that. But the problem has spread up at least to two major cities, Hyderabad and Karachi. Their tickets should be offered. I have never seen data on XDR from Punjab. They may be collecting it, but I'm not aware of, I'm not privy to it. So if they have that high number of cases, that's high burden of disease also. Not only that, okay, we are getting 20 cases of typhoid and 8 of them are XDR, but what is the burden of disease in that population, which will then make you should do the risk assessment that this intervention cost me that much money and will give me protection to that percent of population. What are my alternatives? So this is not done routinely in Pakistan, where the government officials sit down and do, instead of feeling that, we should invest on dengue, actually look at different disease burden and decide what interventions are most cost effective and how we should implement in our population.
Dr. Umar, I think now we should wrap up this session. We have taken much time of ours. They have a busy schedule.
It's Friday after 5 p.m. and I'm amazed there are still 40 people logged in.
Yes. Yeah, people logged in from UAE, from UK, from Singapore. So that's.
So our Pakistan friends have gone for the long, for the weekend now. They have left.
Yes.
No,
Dr. Farooq, your closing comment.
No, I think this is humbling, and this is heart kind of breaking on the both ends, that the disease burden is pretty high, right? So, and then when things could be prevented before they reach to a certain level, I think we have let a lot of these conditions reach to that level. Now we have to go to the next level of prevention and treatment. So I think one common theme is treat it right in the first place, but before that, prevent it right in the first place. So thank you, both participants. Thank you, Dr. Heather, and both speakers, and thank you, Dr. Heather. And I also want to thank all the participants for the live chat. And we are privileged and proud that we answered some of your questions. So stay tuned. I think the credits, CME CD credits will be shared through emails, and there will be some follow-up communication. And we look forward to see you again.
Yeah, so I have an announcement to make. So we are holding a one-day symposium on World Day on March 24th with the help of Health Department and WHO. So I'll request everybody to stay tuned to our webpage of the CME and CD program, and we'll be posting our updates over there as well. And we'll see Dr. Asghar and Dr. Somia in our future sessions as well, to keep bothering you.
My pleasure, and thank you for giving that opportunity. Thank you very much. Have a nice weekend, guys.
Thank you. Thank you so much, everyone.